So this is along, I believe, also along Highway 56. It's up in the northwest corner of Montana. Very scenic, beautiful road. It's around where I grew up. So this is esophagitis and esophageal neoplasms. There are the websites that Dr. Hughes and I have for the USMLE questions. My Twitter, which I keep saying I'll go back to, and I should, hopefully pretty soon. And then, like I said, remember, I'm a forensic pathologist, but I really have a strong interest in just general and organ pathology, natural disease, and in teaching medical students. So I hope from that I offer a more not specialized perspective on it that helps you all learn. Here are two of my 3 disclaimers. Please pause, read this, make sure this does not apply to you. I want to teach people pathology, but I want to make sure that people viewing these are the ones supposed to be watching them. So if any of these apply to you, don't watch the videos. Same thing, pause. There's a 3rd disclaimer. Make sure it does not apply to you. And then if you're interested in my teaching style, I made the presentation called Introduction. Most people haven't watched it, which is perfectly fine. But just if you're interested. These are the references I use, all really great books. I recommend all of them, to tell you the truth. Otherwise, I wouldn't list them. Okay, so I start each with a question. So pause, look at it. This helps you concentrate on certain areas of the lecture and has been shown to help retention time that we'll go through at the ending. But the idea of these is that you haven't actually seen this material, so you shouldn't actually be able to answer the question. But in looking at it, it makes you think about it, and then it kind of hones you into the lectures you go through, and it actually has shown to increase retention time. So we're going to talk about esophagitis. So esophagitis, obviously, is inflammation of the esophagus. There's a variety of etiologies that can occur, that can cause it. Any type of exposure, chemicals, alcohol, acids, alkalis, smoking, pills, also things, other exposures, radiation, chemotherapy. Some skin lesions can actually affect the esophagus, pemphigoid being one of them. You can get infectious forms of esophagitis. Commonly, these are seen in immunocompromised, so CMV, HSV, fungus as well. Reflux. The esophagus is designed with stratified squamous epithelium, so to protect the esophagus as food moves down it. The stomach is designed to hold acid. If that acid refluxes up in the esophagus is being exposed to something it's not normally exposed to, and then can contribute to inflammation. You can see an eosinophilic esophagitis, and this is associated with other atopic diseases like asthma and that. And then clinical findings, you can imagine you could have some degree of dysphagia, chest pain and that, but odynophagia, so pain with swallowing, because if your esophagus is inflamed and food's going down it, it's going to hurt. So one thing about this is that's important to remember with the GI system is that neoplasms vary around the world in their incidence. Some places it's very common to see certain tumors, other places it's very rare to see those same tumors. And a lot of this comes from diet. There's a lot of different diets around the world, and that diet affects it because it's moving through your GI tract. So it's just something important to consider when you think about this. Most of my numbers are going to be based upon the U.S., I'm sorry, but consider that other locations with different diets, different exposures, have different instances of these tumors. And sometimes I mention it, but sometimes I don't always. So just something to always keep in mind. So here's one of my favorite pathologic conditions, black esophagus. It looks black. This is one of the better examples. I've seen multiple like this, though, where the black of the esophagus is just very striking. You can see the white arrow. That's a GE junction, so it ends right at the GE junction. It's also called acute esophageal necrosis because if you look at the right, basically the mucosa is entirely replaced by inflammatory cells and this kind of stippled yellow-black pigment, which is apparently digested blood. And in this case, the inflammation goes all the way down the muscular layer. And I see this commonly associated with diabetes, especially people in ketoacidosis, and also with hypothermia as well. HSV esophagitis, like I said, HSV esophagitis, CMV, and fungal are commonly associated with immunosuppressed patients. They say HSV is seen with, is described as punched out ulcers, and CMV is more shallow, but I'll show you in the next slide. It's not always shallow. And so with HSV, you can see the Cowdrey A or Cowdrey B inclusions. Cowdrey A looks just like CMV. To the right of it, it's kind of like that, but not the best. Both these look more like Cowdrey B, and then I see some people don't use Cowdrey A, Cowdrey B. But anyway, the HSV can cause inclusions that look like CMV, with a basophilic inclusion with clear halo. And also you can see more to the top left is characteristic of it also, multinucleated infected cells with kind of a smudged nuclear inclusion. So the black arrows show the inclusions. There's plenty more around if you look. So here's CMV. So the top left is actually the lesion. So to me, that's not really shallow. Basically goes down to the muscle. And that was the lesion where the CMV was. So the yellow arrow shows the lesion, and this person had a GI bleed. And to the right of it is the CMV. And you can see large cells, nice basophilic inclusion with a clear halo around it, basophilic intranuclear inclusion, although you can also see cytoplasmic with CMV. And then this, again, immunosuppression. And then candidal esophagitis. I had a really great case where the esophagus was green, but I can't find the pictures of it. But this one shows the top left is H&E. The black arrow shows one of many. You can see the hyphae in there. And the bottom right is a GMS, Grocott methenamine silver stain, stains the organism. So all the black you see is all the fungus. So reflux esophagitis would be probably the most common one that's seen, also called gastroesophageal reflux disease or GERD. And so usually it seems like it says most commonly it's greater than 40 years of age, but can occur in infants and children. So, something you don't want to rule out at a younger age. So basically what's going to allow reflux, the mechanism would be if you have decreased lower esophageal tone. So something's got to keep that GE junction tight so that stuff in the stomach doesn't come back up. So if you decrease the tone, that's going to allow stuff to leak back up. Also increase abdominal pressure, same thing. It's going to put strain on that region and allow stuff to leak back up. So alcohol, I think, is known for relaxing things. Is my way of looking at it. Smoking is just damaging. Obesity, that could be from potentially the increased abdominal pressure. And then increased gastric volume. If you have more stuff in the stomach, it's going to put strain on that and allow stuff to leak back up. So to me, if you can look at something and kind of explain it to yourself, or how does this make sense, or stuff like that, it's a lot better to me than just memorizing a list. Hiatal hernia, where you have basically stomach above the diaphragm, can do it. And to the right of it, the black arrow shows the open esophagus, and the yellow arrow shows the stomach. And to the right of that is going to be where the diaphragm is. And so that was basically stomach that was prolapsed above. That would be a hiatal hernia. Clinical findings, heartburn, so that kind of that reflux of that acid. Dysphagia, difficulty swallowing because of probably irritation, stuff like that on it. And then also the reflux could make them regurgitate gastric contents. So when you get ulcer up in the stomach contents up in the esophagus, the acid can obviously lead to an ulcer. Barrett's esophagus, we'll talk about with metaplasia, the change to a intestinal type mucosa. If you have an ulcer or other inflammation going on, you could have hemorrhage. And then when you have injury to it, it could cause stricture. So reflux esophagitis and eosinophilic esophagitis are both similar in that both of them contain eosinophils. That's how you make the diagnosis. But with reflux esophagitis, there's just a couple. So if you look at that picture, there's just a couple eosinophils here scattered here and there. That was reflux esophagitis. Whereas eosinophilic esophagitis, which is a separate condition, has prominent eosinophils. And if you look at that, there's just eosinophils all over. So I like to put a picture halfway through just for something to break up and look at. This was along the Moise Bison Range. These are just some falcons and stuff. Hawks. Sorry, I don't know my birds as well as some other people I know. But anyway, just kind of neat. So Barrett's esophagus, when you have long-term reflux of that gastric acid up in the esophagus that's normally not designed to handle that changes. So it changes something that is better, which produces this intestinal type metaplasia. So it looks more like intestinal type epithelium with goblet cells in that. So it's metaplasia. But remember, metaplasia can lead to dysplasia, and dysplasia leads to carcinoma. So with Barrett's, goes along the lines of reflux. So reflux, it says more commonly greater than 40 years of age. Here, greater than 40 years of age. And then males greater than females. And then, like I said, that metaplasia leads to dysplasia. Dysplasia leads to adenocarcinoma. So this is an example of Barrett's esophagus. So let me explain the pictures. To the bottom left is normal esophagus. So you can kind of see it's not perfectly normal. There's kind of like a hemorrhagic discoloration right at the GE junction. But you can basically see to the right of it, the gray of the esophageal mucosa goes to the gastric mucosa, and that arrow indicates the line. Well, the corresponding line on both the pictures is the black line and the yellow line. But if you'll notice at the top left top right especially, the black line above it almost all looks like the stomach to the right of it. You see at the arrows some little islands of colonic mucosa. So everything above the GE junction almost for a short period of time has converted to more of an intestinal type epithelium. To the right of it shows the same thing. The yellow line to the left of that is the stomach, to the right of that is esophagus, but there's very little gray stratified squamous type mucosa. You can see some at the arrow and stuff like that. That's not as good of a picture as the other one, but they're both very striking examples of Barrett's esophagus. So remember, Barrett's esophagus is a metaplasia. It's a change in the type of epithelium based upon the stressor, the gastric acid that's there. But metaplasia leads to dysplasia. Dysplasia leads to carcinoma. So the top left is the intestinal type metaplasia. It says goblet cells are the defining feature. At the black arrows, you can see some goblet cells. The bottom right of it shows dysplasia. So to the right of it is Barrett's esophagus with, you can see goblet cells and everything like that. And to the left of it, if you compare the two, it's much darker. There's a higher NC ratio. It's more hyperchromatic, and you really don't see too many goblet cells. So to the left of it is high-grade dysplasia, and once that invades, they have adenocarcinoma. So we'll move on to esophageal neoplasms. So the two main types are going to be adenocarcinoma and squamous cell. Adenocarcinoma, as we just talked about, is associated with Barrett's esophagus. So it's going to be in the distal third of the esophagus. Squamous cell carcinoma is often the middle third of the esophagus. Both of them can be exophytic ulcerated. You can see adenocarcinoma in other areas. There are glands in the esophagus. If one of those gave rise to a neoplasm, you could see an adenocarcinoma anywhere. But normally you'll see it in the distal associated Barrett's. More commonly males and females when we're talking about adenocarcinoma, and that we're talking about with reflux, more commonly males and females. And then, as I said, the regional rates vary greatly around the world. That's because of diet and different things that people eat and stuff like that. It says very hot liquids are associated with a risk for esophageal cancer and stuff like that. So that's just something to consider, that a lot of my numbers are going to be based upon the United States. For the most part, I talk about other countries a little bit here and there, but it's going to be highly variable, and it depends upon that diet, because the GI tract is the diet's what it's exposed to. And so, okay, so here's two examples of esophageal carcinoma. To the top left, you can see the esophagus and the stomach with the arrows, and then in between them, you see the neoplasm right at the corner there, at the junction between the two. To the bottom right, there's actually two. There's actually one, white arrow at the bottom and white arrow at the top. And I think it was just actually the same neoplasm, just I can't remember exactly how this connected and stuff, but it was an esophageal neoplasm. So adenocarcinoma, as we've already talked about, associated with gastroesophageal reflux disease or Barrett's esophagus, also smoking and obesity. I personally think of most tumors, if you have a choice of smoking, probably most likely it's a good chance. Clinical features, dysphagia. So you can imagine if you have any type of stricturing or any type of scarring or anything like that, it's going to make swallowing more difficult. Weight loss, partly because of probably difficulty eating, but also just the caloric requirements of the cancer itself, and then can get chest pain as well. The mutations associated with it says early on you'll see mutations of TP53, and then obviously it's adenocarcinoma, so it's going to have glandular differentiation. And then squamous cell, this one's one associated with alcohol, smoking again, achalasia, we'll talk about Plummer-Vinson syndrome, and then consumption of hot beverages, which I just mentioned, which probably is more of a regional condition around different parts of the world, more commonly male rather than female. Usually it's a disease of older individuals, greater than 45. I have to be careful because I'm in that range, so I can't call myself too old. Clinical features, dysphagia, again, just difficulty swallowing because of the mass itself, stricturing, potentially pain associated with it, and then weight loss, just probably difficult to eat enough nutrients, and also the cancer is going to take nutrients of its own. And then this one, it talks about the amplification of the SOX2 gene. So here's the question. So pause, read it, answer it, and then we'll talk about it. So a 53-year-old male presents to an acute care clinic complaining of difficulty swallowing solid food, which has progressed over the last 3 months. He has not seen a doctor in 30 years, even for his frequent heartburn, for which he has always just taken over-the-counter medication for. So heartburn would go along with gastroesophageal reflux disease. Associated with difficulty swallowing, he has also lost 15 pounds. So once again, dysphagia goes along with cancer, and then weight loss. However, he thought the amount of weight loss was disproportionate to his difficulty eating, so he's losing extra. The cancer has caloric demands. EGD is scheduled, reveals a mass in the distal esophagus. Microscopic examination mass reveals infiltrating neoplastic glands, so it's an adenocarcinoma. Of the following was most likely etiology for this condition, and it's going to be chronic reflux. So this will be a person who has gastroesophageal reflux disease, developed Barrett's esophagus, developed dysplasia, developed adenocarcinoma. So then once again, use reflection, think back through the lecture and go, okay, what are 5 important points that were made? And like I said, according to Make It Stick, one of the medical students went from the bottom of their class to the top of the class using this one technique. So that's why I don't give a summary slide. I want you to summarize for yourself, and I hope I've brought up 5 important points. So here's my last one. This is somewhere in northwestern Montana. I think this is along Ross Creek Cedars, just a random creek and stuff like that. And if you want to read a description of creek versus crick, read Patrick McManus. He has a really good description of it. So I hope this lecture has been useful. Thank you.